Hey everyone, welcome to episode 4 of the Happy Hour Chat. So today we're talking with a physical therapist, and not just a physical therapist, but this, in my opinion, is one of the premier physical therapists, the best physical therapist in the state, if not the country. I've had the privilege of working alongside her for a few years, but this is Kerrie Brooks. She's owner and operator of Sports and Orthopedic Specialists, and she has an extensive bio. So first of all, I just want to welcome you to the show. Thank you for taking the time. I know you're still doing some telehealth conference calls with some clients and patients.
Oh, thank you. This will be fun. I'm looking forward to it.
Awesome. So I am drinking a vanilla porter from Breckenridge Brewery, which is in Colorado. Kerrie is drinking some water, but we'll be.
It'll soon be a Pinot Grigio.
Probably a little bit later, right?
Yeah.
So I'm going to go over your bio a little bit, but before that, I want the listeners to know that I want to sort of cater this discussion more towards the education side of things for other therapists, for personal trainers, massage therapists, because I think you have like a wealth of knowledge from a lot of years of doing this, and you're just a really smart person. You really get the body very well. So quick bio on you. I don't like to spend too much time on this, but you earned your doctorate in physical therapy from Shenandoah University. That's correct, right? In Winchester, Virginia?
Yes.
Okay, cool. You also obtained a specialist certification from the Hospital of Special Surgery on hip rehabilitation. And you are a Polestar Pilates instructor, which I know is a big part of your rehabilitation process and treatment protocol.
Yes.
I think a lot of people might know you through working with the Williams sisters. You did that for about 9 years. You traveled with them exclusively on the WTA tour. And obviously you've worked with other tennis athletes, ATP, LPGA golfers, PGA golfers, Major League Baseball. So you're kind of known as a sports physical therapist. You've been featured on CNN Headline News, ESPN.com, Tennis Magazine, Self Magazine. I can go on, Fitness Magazine, all those things. And then back in 2010, you were the keynote speaker at the Chinese Sports and Fitness Forum Conference in Beijing. Pretty long bio, pretty extensive.
I'm old, Kenny.
What's that? Yeah.
I'm old.
It's always kind of awkward too, right? When people start listing these things off, you're like, oh God, I got to live up to this. But I wanted to kind of cater and gear this conversation towards tennis, in particular the junior athlete. We both work with tennis players. I know, like I said, you've had a lot of experience working with them. How did you get started working with tennis players? Because I know you started working or traveling on tour WTA pretty early in your career. Is that right?
Yes. So I actually just kind of became acquainted on a professional level with a lot of the WTA physical therapists through some training and certification coursework or continuing education coursework that we were taking. And so I kind of developed a relationship through that, and then was invited actually to interview and come work for them. And it just happened at that time that they had a hiring freeze because they lost their corporate sponsor. And so it just happened at that same time that the Williams sisters were starting to look for a physical therapist. And I interviewed for that job and got that job and just stayed with them for the next 9 years. Because
how old were they when you started?
Fun girls.
How old were they when you started working with them?
I started with them in 2000. So Venus was not quite 20, but she's basically 20 years old, and Serena was 19. She had just won the U.S. Open in '99. I started right after that. Right.
And we're going to get back to tennis here in a little bit, but just maybe tell the listeners a little bit about your practice. I think it's fairly unique in that you incorporate Pilates as your main form of rehabilitation and exercise. I know you do a lot of hands-on, a lot of manual work with patients. But just tell me a little bit about what brought you towards that. In other words, getting away from the typical physical therapy interventions and moving towards more of this Pilates-based rehabilitation.
Well, I think over the past probably 10 to 15 years, in general, we have started to understand and comprehend more and more how the body works. And we've gotten a little bit away from that myopic view that, if somebody comes into you with a shoulder injury, that you just do shoulder exercises and forget looking at the rest of the body.
Right.
So kind of out of that growth and development, that really we need to look at the person and look at the core and how the shoulder necessarily in this case ties into the core and core stability, and really looking at the person as more of a big picture or a whole picture, not just an injury part. That's really what kind of led us to learning more about Pilates and how the spine and how the core helps facilitate or inhibit upper extremity or lower extremity function. So it kind of evolved from that, just trying to look at the picture of the person as a whole picture instead of just a part.
Right, and that the body essentially moves with everything as moving parts working uniformly together.
Yeah.
So if
And
you
so
do have a
we in our clinic, we do one-on-one for an hour with a
Yep.
patient, and there's some manual work. We might work on soft tissue or joint mobilization or just kind of neuromuscular re-education, trying to teach a person how to move a part properly again, or how to integrate their activation sequencing. So there's a lot of hands-on, but it's amazing when you actually spend time with a patient and really get to see how they move and how they perform, that you get a better understanding of why they got injured to begin with.
do you ever have to do any convincing with the patient? Because sometimes I think this could get carried away in some degree, and I think it does on occasion where, if someone comes in with a shoulder problem, it's because that left ankle doesn't dorsiflex very well, or that left hip doesn't have any internal rotation. And then we go down this rabbit hole trying to fix all these other body parts, and then wait a second, what happened to the shoulder? But, like you're saying, there is a component to that. So is there any convincing you have to do? Because a lot of times people are going to I want you to work on the shoulder for now.
Yeah, and I think that it's not as hard of a sell or as you'd think with people, because they start to understand that, oh, wow, when I can't move my hip this way, oh, no wonder I can't turn and rotate my trunk, and that's why my shoulder is being affected or getting injured. So it's not as hard of a sell as you would think it is with a patient. I think that they are a little bit better comprehending the tie-in. But you do have to be careful not to get overwhelmed in the details. And,
Sure.
There's a saying I always think of sometimes that they say, when you hear hoof prints, don't think zebras. So you really have to try to still stay focused on the main parts.
Right. So getting to junior tennis players, I know they make up a big part of your clientele and patient load, as does older athletes as well. Where do you find that they get injured the most? And it seems like junior tennis players are more apt to injury, especially when they're going through their growth spurts. So what is the part of the body that you find, oh man, I got to deal with this again, this is just becoming a problem, that sort of thing?
I think in a lot of junior tennis players, we see a lot of upper extremity issues, shoulder, elbows, wrist. And I think that comes with, they tend to be thrown into this environment sometimes where they're hitting with such a lot more intensity or a lot more repetition, and they don't have the maturity in their body to be able to handle it, or the proper sequencing and motor patterns or basically technique to be able to hit that volume of ball and with that intensity. So that's, I think, what really leads a lot of this injury in junior tennis is just they just don't have the physical maturity or the techniques to be able to hit at the volume that they're trying to hit at. And then that's when you start to see things breaking down.
Right. So typically the wrist, shoulder, elbow, those are common areas that get overworked.
Those are probably the most common injuries. We do see our fair share of knees and ankle sprains and things like that. But with a lot of the overuse injuries and chronic injuries, it tends to be, I personally see a lot of upper extremity injuries.
And you would say most of that is due to overuse? Just like you said, the body hasn't really acclimated yet. It doesn't have the tissue tolerance to absorb or create the forces that they are generating. Because in a lot of cases, these kids are not big, but they're able to generate a lot of speed. So they don't really have the structure to handle what's happening.
Yeah, and a lot of it, when you're just learning, you're perfecting your techniques, you're changing things up a little bit. Sometimes they're teaching them drop the wrist a little bit more, flip the wrist a little bit more here, or just little subtle changes in those strokes. When you do that thousands and thousands of times,
Right.
that can start to create injuries and create problems.
So what's your opinion then on, we've probably talked about this in the past, but what's your opinion on this, on junior tennis players practicing as much as they are and playing as much as they are? Because I see a lot of my clients are tennis players as well, and pretty much tennis is all they do. There's, from the ages of 9 to 10 all the way until they go to college, tennis is number one. And I have this conversation a lot with parents, say it's really important if you try to get them involved in other sports, just at the very least to take some stress off that repeated motion that they keep doing over and over again. Is that a problem? Do you find that's becoming a problem, especially down here in Florida because the weather's great year round?
Yes, definitely. I think that there is a huge problem with overuse or just too much practice, I should say, for tennis players. And I would also love to see them get off the tennis court occasionally and go play soccer or something like that. Just do
Right.
something different,
Yeah.
because they just are so myopic in that approach, and they just hit a lot of tennis balls. They tend to do it year round, and that creates a lot of injuries. And a lot of these kids, they have a hard time really following through with tennis because injury takes a lot of them out of their sport. And it's frustrating to see that. I just really wish that there would be a more variety to the training and to the sports, that would help cut down on some of these injuries.
You
You see
communicate that.
athletes like Rafael Nadal. Rafael Nadal played a lot of soccer growing up. I just think,
I'm gonna tell you about a study that was done. This is back in, the study was done. It tracked about 1,000 junior tennis players between the years of 1994 and 2002. It was done in Poland. You might know about this study. I'm not sure not. But 40 countries are involved. The average age of the kids that they tracked was between 12 and 13 years old. And what they found was that the better players as adults were smaller than average for their age, were less powerful at the time. They were faster, more agile, and they started playing tournaments at age 11. And they really only played about 45 to 50 singles matches a year. Now, they also only practiced around 10 hours per week, which was below the average for the group as a whole. Now, some of these athletes, what we later found out that were documented in the study, were Kim Clijsters, Roger Federer, and a lot of other notable tennis players. So it was pretty cool because it tracked them for so long. And another thing they found is that a lot of the better players as adults, as professionals, actually involved themselves in more fitness sessions than the other players in the group. So maybe the kids that were better at that time were not engaged as much fitness and were playing more and more matches throughout the course of the year. And so what they were finding was that burnout was very big. They did another study I found, which they looked at 1,200 kids. This is between 8 and 13 years old. And they found out essentially that kids who spent more hours a week than their age at that one sport were 70% more likely to have a serious injury or burnout from the sport. When I read statistics like that, I feel like that's pretty convincing. And, if parents could only kind of understand that aspect to it, that the best players in the world were multi-sport athletes. They didn't necessarily focus on their sport until they were maybe 13, 14 years old, 15 in some cases. So I don't know. I just found that pretty interesting, and I can kind of backs up what you're saying.
Yeah, I think just in tennis, sometimes the mentality is you see all these other kids out there hitting for 2 and 3 and 4 hours a day, and you just think, oh, well, I should be doing that.
Yeah.
Like, no.
Right.
Just because somebody else is doing it doesn't mean that it's right or the best thing to do.
Right.
So I think there's a lot of peer pressure because they see a lot of these kids at the academies and even not even at the academies, but just on the courts, just hitting for hours and hours a day. And it's not the smartest training method. At least in my opinion.
So I want to get back to kind of what you recommend, but maybe later on. So let's talk a little bit physiology. What goes on with the adolescent growth spurt that seems to make them more prone to injury? Physiologically, you say with regards to the growth plates, all that stuff. Because I'm going to say I don't know much about growth plates, and I have a feeling some other trainers might not either. But I'm very interested in what happens.
Well, just to not get into too heavy of a detail with this, basically, as an adolescent is growing, their bones, in essence, grow faster than their muscles and tendons can.
Right.
And when that happens, that bone lengthens, and so it puts tension on the muscles and tendons. And when you put tension on the muscles and tendons, they can pull on the growth plates, or which are basically the ends of the bones that are growing. And when you combine a lot of activity, like a lot of running or a lot of playing one sport, those muscles get tighter just from playing a lot of that one sport. And so now you add on a lot of increased activity to a muscle and tendon that's getting stretched and pulled on, and it starts to pull more and more on the bone. And that's what creates these apophysitis or growth plate injuries, Osgood-Schlatters types of injuries. I'm sure people have heard of that one. It's Sever's disease, which is down in the foot and the heel, but it's just from an overuse during that adolescent time period. And the only thing that really helps that to get better is you've got to rest, cut back on your activity, and try to just start stretching a little bit to get those muscles and tendons to start to lengthen a little. It just takes time. Your body will catch up, and most kids will outgrow those, but it just stinks during that time that they're having to go through that because they're not getting to play any sport for that matter during those periods.
Mentally frustrating too, I know, for parents and for the kid. They feel like I'm never going to get better, but then you end up finding them back on your table again because they didn't necessarily heed your advice. And that kind of brings me to the next question. You have always kind of, in my experience with you, you've always kind of erred on the side of caution with patients. Back off, take yourself out of the situation that's causing the pain, modify things at home. Do you find that those type of instructions and guidelines work a lot better than maybe just putting someone right into an exercise routine? I mean, in my experience, I kind of followed suit with what you had always taught your patients, and that's sort of, okay, what hurts? Why is it hurting as you're doing it? Now let's see if we can modify the movement to make it not hurt, but in the meantime, we're going to back off doing this, this, and this. That makes sense.
I think there are some injuries that you have to just totally rest it. You just have to let it calm down. And then you can start to reintroduce things using pain as a guide. Things that aren't hurting, things that are maybe a little bit more diverse and we know don't necessarily put pressure right on this injured area, knee, foot, whatever it might be, and start to kind of work on developing other things while allowing that tissue to heal. So, and I think that goes back to the whole beginning of our conversation where, hey, maybe we need to go back and start looking at a person's overall strength and core stability and motor sequencing and just see if you can start to work on that a little bit, and that might help this injury as well.
So let's say you're dealing with a tendinopathy, which is probably something that's pretty common with athletes when they come in that are related to, say, overuse or micro tears. How much pain, because the research does show in some of the literature that working through some discomfort on slow eccentric type work, either through an Achilles tendinopathy or whatever it may be, will have good effects on bringing that person back into action quicker, but it might hurt while they're doing it. And my understanding is that it's okay if it hurts during it, as long as it doesn't hurt after. What are your thoughts on training through that? Because I think there are two sides to that.
Well, I think a lot of times you will find that when they first start to come back, things do hurt a little bit more than they maybe used to before when they used to do this certain activity. So I'm always a big believer in first, just let it rest first. Just let it calm down and then start to slowly work on reintroducing eccentric loads and things like that to tendons. And really working around it is an approach that I like to take. Work on some other things and slowly work that injury or that body part back into the same exercise or same routine that you were doing.
Will you start them with an isometric? Do you start them with an even tempo of concentric eccentric? Do you go right into eccentrics?
So a lot of times, if tendons are involved, a lot of times we will start with sometimes isometrics and then work into eccentrics. And usually as a guide, we'll say, don't ever do an exercise that your pain goes above a 2 out of 10. And that's usually like a mild level of pain. And something that once you stop the activity or stop the exercise, it should go away. If it's not going away, then that might have been a little bit too much.
Right.
Been maybe a little bit too much load, and you just back it off and modify that.
So how do you determine, I mean, you end up, in these situations, you end up kind of becoming the leader, the coach. It's, I know the instructor ends up looking to you, the parents look to you, the athlete obviously looks to you. So there is some degree of pressure on that. How do you decide when an athlete is ready to return to their sport? There's certain benchmarks you look take? And you can even give me a certain body part if you want, for example. But I'm just kind of curious as to, do they have to pass a series of physical tests to go back? Is it just that they can play pain-free? How do you do it?
So for tennis, for example, we will have them kind of just really look at it. Basically, we will say first, you have to get through your daily routines without pain. Like, can you just take care of yourself and do the things you normally do on a day-to-day basis without pain? Then can you get through your rehab exercises without pain? And then if they can get through those stages, and there will certain, depending on the body part, there might be certain tests that we will do to see how they tolerate those tests. And if they can do those tests, then we'll say, okay, let's have you go ahead and return to practice. But we usually give them strict guidelines and return to practice. And we try to work with the coaches on that too, just so they kind of understand, and we work with them on how they like to structure their practice, because sometimes coaches have different approaches they like to use. And so we try to work within their realms too, and getting the player back. And we'll start with maybe a half an hour of practice and try to structure that practice in a certain way that allows them to start working on this without overdoing it, and just kind of keep working on slowly progressing that. Generally speaking, we try to think of maybe like a 10% increase in intensity and repetition at a time, not more than that.
And then at some point in your clinic, will you put them through something that sort of mimics what they would experience on the court? So if they had a knee injury, that sort of thing, are you going to have them start to do some low-grade single-leg plyometrics just to show that in your clinic they can do it? Because obviously the demands of running back and forth and in the heat of a match is going to put a lot more stress.
Right. And that would be part of their rehab exercises. Those are the kind of things that we'd want them to be able to do pain-free before we put them back on the court.
Right.
So, and that would be a progressive program. It might be something very simple like an isometric exercise to start with, and then progressing to more closed kinetic chain, eccentric loading exercises, and then to plyometric type exercises, or even cardio type of exercises before we say, all right, if you can do all of that, now we can start to put you back on the court and have you slowly progress your practice. And within certain parameters too, again, not having pain escalate over 2 out of 10. And if you start to feel like your pain is escalating, your practice is done for the day, take a day off. So it can go from there.
Do you have guidelines that you've come up with or that you've read about in the past that you like to use to give the parents or the coaches an idea of how much they need to start with? I know you said sort of slowly add maybe 10% in. So let's say it's that the athlete's first day back at practice. They've just rehabbed the shoulder. They're having no pain in the clinic. They've done serving on a very low level, but they haven't really practiced per se.
No, I don't have a specific guideline because it's just so individualized for each athlete. Right. So, I mean, we have general patterns in our heads that we are trying to follow that, but it's hard to say, just follow this one protocol. And I know sometimes people like protocols that you can kind of follow, and those
40
are
serves
general,
first week, 60 the next week. Yeah, I got you.
Right. They're general guidelines. Sometimes you just can't use that specifically and just go by that. You have to modify it a little bit for each athlete, but we'll follow general guidelines or protocols that have worked in the past.
So what do you recommend for the athlete that has just hurt themselves? They did something to their knee or their shoulder or whatever. I get a text, this hurts. I end up sending you a text in some cases. What process should they be doing? What should the parents know? What should they do with their child when an injury occurs?
Well, the first thing I would say is just let them rest for a couple days. Sometimes it depends on the severity of the pain. If somebody, if there's a 12-year-old that comes off the court and they're in tears and crying and can barely walk, I think I might get them into a doctor a little bit sooner. But if it's, a tolerable level of injury and pain, I might say, okay, let's just try to do some rest. Let's maybe try some ice if there's some swelling on the tissue. Let's just take the load off, let it calm down for a little bit. Might get them into the clinic. Let's see if we can evaluate them. But if it's something that there's red flags that are popping up, or if it seems like it's a pretty severe amount of pain, I usually recommend, why don't you just try to see a doctor first, and let's just get some diagnostic imaging and get evaluated by a physician, make sure that we know what we're dealing with.
Right, and that might be, like you said, someone who can't put weight. There's no weight bearing on it. They've got maybe nerve pain running down a leg or an arm, that sort of thing.
Yeah, a lot of
Red
weakness,
flags.
a lot of swelling, difficulty walking, pain at night, those kind of things that
Yeah.
just make you go, oh, this could be a little bit more serious or severe. And you just want to make sure that you have all the information that you can, so that you can really have a good prognosis and really do the right treatment and protocol for those patients.
Now, you might have a different opinion on this. I'm not sure. A lot of times I tell my clients when they do have an injury to go see someone like yourself, a physical therapist, and someone like you who works in an exclusively one-on-one manner, who can do a really good clinical evaluation. And what I end up, what I advise them to do that for the reason that I think, and with all good intentions, orthopedic surgeons, they do have good intentions. They want the person to get better, but I would say their clinical evaluation is not quite as extensive as what you're capable of. Is that accurate?
Well, I don't want to.
Like that? And the orthopedics watching, like, this guy, I'm never working on him. If he
This girl thinks she is.
Well, I mean, orthopedics, they kind of deal with bones and nerves, that sort of thing.
Yeah.
You guys are more on the kind of like the software, not the hardware so much.
Yeah. I think there are some, I have a good relationship with several orthopedists that I just think are brilliant diagnosticians. And
Right.
I really, really value their assessment and their evaluation, because I think they do a fabulous job. It is disappointing sometimes when you can hear of a patient going in to see the doctor, and the doctor doesn't even touch them.
Yeah.
And you just think, gosh, okay, did he have you walk? Did he watch you walk? Did he see that? And so that can be frustrating, and that is definitely less common than not. But yeah, just getting the proper diagnosis, that is half the battle, because if you don't know what you're treating, you can't pick the right treatment for that patient. But
yeah. Do you recommend, or what are your thoughts about MRIs? I know, speaking to other PTs, I would say that are on your level, their MRI is just another thing we can factor into the equation. It's going to give us some more information, but don't live and die by what it says. Is that something you would agree with?
Yes, and a lot of times I would say just wait before you even get an MRI. If it's something that's not real severe, just wait a little bit and let's just see if we can get it to calm down without doing the diagnostic testing. Because I think there definitely is a much heavier emphasis on diagnostic imaging, whereas we have these skills and all these tests. I mean, there's for the shoulder, there's just a million tests you can do that you can pretty much figure it out within a pretty good certainty of what the injury is. Occasionally you're going to get surprised by an MRI and go, oh, okay, wasn't expecting that to show up. But
right.
That's why we have these tests and evaluations, so that we can determine what's going on. When something doesn't make sense and somebody isn't progressing and getting better, then I think it's time for them to get an MRI, but not always right away. That's not always our jump to. And MRIs, for example, are a static image done in supine, so they don't really sometimes give you a lot of information, and you have to be careful not to read too much into those if it doesn't correlate to what your symptoms even are. So you have to be careful not to overread those too and get caught up in what you see on there.
Yeah, and I think another thing too that a lot of our maybe older clients and patients should probably understand is that if they were to have an MRI of their back right now, they probably wouldn't like what they saw. They might not have any pain, I mean, and so that's another thing, like you said, you can't necessarily attribute injury to the pain source, because there's probably a lot going on there.
Yeah, it would probably be scary if all of us had MRIs.
I know. Well, I saw a study, and I posted this on social media. It's probably like a year ago, and they took a woman who was having some ridiculous leg pain, and they brought her to like 10 different imaging centers. They had her get 10 different MRIs. And so basically at the end of the study, they found out that not one of the MRIs was consistent with another. One of the MRIs, in fact, showed that she had herniations at all 5 lumbar vertebrae. And another one showed that she had not. no herniations. I know that's hard to believe, and but it just kind of gets back to a little bit of like, you know, you are not your MRI. Although it can be very helpful, and it's another piece of information, especially when nerves are related, I think.
Yeah.
But don't look.
You really have to correlate the findings to what the symptoms are.
Right.
And
right.
sometimes there's nothing on that MRI that correlates to what your symptoms are.
Correct.
And, you know, I always tell people when they get an MRI, you know, sometimes they'll get back and they're like, well, it didn't show anything, but why is my knee hurting? Well, that's a good thing that it didn't show anything, but the MRI is not the answer. Sometimes it's in the way you're moving, the way you're bending your knee. That's the problem. MRI is not going to show that.
And that it's what you do is so huge, because what you're doing is you're re-educating movement. You're replicating the problem. You're getting them to create the painful movement, and then you're re-educating them about how to do the same movement, but maybe a little bit differently. Maybe if it's a knee problem, to load the hip a little bit more, and then bringing them back to the activities of daily living involve being aware and conscious of what you're doing and how you're doing it, to avoid that repetitive process of information, which is over and over and over again. And in the process, you're trying to get them stronger at the same time.
Exactly.
Anyway, I will end it there.
Well said, Kenny.
So I appreciate you doing this with me.
Oh, it was fun. It was good to catch up with you.
Yeah, it's good to catch up too. So hopefully our break won't be too long, and we'll be getting back to work
I know.
by June. I think that might be, hopefully that's accurate, but we'll see.
Yeah.
Anyway,
I just hope people stay home and everybody stays safe, and hopefully we can stop this darn coronavirus.
So you don't have social media, is that correct? You're so busy that you don't need it.
I technically have it, but I don't really. I put Katie in charge of that. She's the head of social media.
So I'm going to ask you a question. This is going to be a tough one. What is your website?
My website, I have the answer to that.
All right.
That is www.sospbg.com.
sospbg.com. So
Yeah.
that's how people can reach you, and they can probably contact you through the website, right?
Yes.
Awesome. Great. Well, take care.
I make sure that is my website. Okay.
I knew it'd be a tough question.
Yeah, I'm not good with the social media.
Awesome. Well, thanks so much, Kerrie.
All right. Thanks, Kenny. Have a good day.
Take care.
Bye.